Hey guys, welcome to ST3 Hacks, and today's episode we're going to be going through Olecranon fractures and how you should approach them in your ST3 national selection interview. This is a small topic, but hopefully we can go through this quickly and you have a better understanding at the end of this episode. The main things you should be understanding about this pathology is that you understand the extensor mechanism, integrity, stability, and patient selection, rather than naming just a fixation technique. As usual, we'll start with the background knowledge you should already have in your head, and then we'll move on to how to structure your station. So first, the pathoanatomy. The olecranon is a part of the proximal ulna and forms the posterior buttress of the elbow joint. The key thing to remember that it's not just a bone, it's the insertion of the triceps with the anconeus contributing laterally. That's why displacement matters. Once the fracture moves, you lose this extensor mechanism. This leads us nicely into the displacing forces. So the tricep pulls the proximal fragment proximally and posteriorly. The anconeus contributes, pulling it laterally. So even looking at a simple transverse fracture can displace once swelling settles. Classification-wise, the one that people most expect you to orientate around is the Mayo classification. Type 1 fractures are undisplaced. Type 2 fractures are displaced but stable. And type 3 fractures are unstable, often associated with elbow instability or dislocation. Each of these three types have a type A and B, and A stands for non-comminuted and B stands for comminuted. You might also read or hear about the Colton classification because it includes avulsion type injuries, but I don't think it's really relevant at the ST3 level. Maybe FRCS, I guess we'll all find out. On the radiograph, you should be able to describe a displaced transverse olecranon fracture, commenting on displacement and comminution. Standard views that they normally will give you are AP and lateral, i.e. orthogonal views, but I think a golden pearl is to ask for a radiocapitellar view, which assesses for an associated radial head fracture, because olecranon fractures sometimes don't come alone. There's no specific guideline for olecranon fractures, but one paper that I did read in my research was Duckworth et al. 2014, which basically said that conservative management in displaced olecranon fractures in older and low-demand patients had similar outcomes to operative management. So that's something you can drop in when they're talking about management when we come down to our station answering. So moving on to how you approach the station. Again, you start with the triple assessment. Ensure you do an ATLS, A to E screen to rule out any other life or limb-threatening injuries. Take a detailed upper limb history. Start your examination in a look, feel, move manner, making sure you rule out open injury or impending open fractures. Assess the extension of the elbow for extensor mechanism functionality. And in investigations, you ask the usual trauma bloods, the radiographs as I've described above, and a CT to guide surgical management or if there's significant comminution. Management should start again in an escalatory manner. So non-operative management is normally suitable with cast immobilization for non-displaced injuries with extension intact, but it can also be considered for displaced fractures where there are frail and low-demand patients, as highlighted by Duckworth et al. Moving on to operative management, the first type of operation that you can do is a tension band wiring, but normally this is for transverse and non-comminuted injuries. If the fracture line is not transverse and is slightly oblique, upper limb surgeons get quite picky, and they then would suggest an ORIF with a hook plate. And the problem with the hook plates are that a large proportion of patients need removal due to metalwork prominence and irritation because it is very superficial, the elbow. And to be honest, that's really it. If there's any questions or anything I've missed or you guys can add, please let me know and I can always add these to the episode for future listeners. Anyway, have a great day and happy revision.